This is not a nice compliment. والله أنت عمر he's very naughty. يعني أنا نخطف بحره بالنوتي. في بحري في النوتي.
يوسف قول له حط لي اس دي اي كده، اس دي اي. لا لا كده اس دي، اس دي اي، اس دي اي، اس دي اي. انا كده ايه؟ انا كده ايه؟ اكيد. بس انا مديك اس دي على فكره. طبعا قطع صوت طلع حوالين بقى والملاقط بقى اول يعني لو ما اشتغلتش عندك انت قول له تحط عليك عشان اقلب هنا الفورمات الاول ممكن احول له سكرين جرب في الاس دي اي ولا في الاس دي ولا في الفتحه انا لو اس دي اي كده هقول لك صيغه ثانيه طمني انا عشان انا البروفيسور لسه واخد عقليات هو شغال انا من على الكاميرا مديني هو ايه صوره ماشي هو ممكن بيديني اس دي مكان بيديني اس دي كنت شغال ايوه طيب حاجه كده قول له حط انا اس دي صح اس دي اي هو خصوصا ما فيش الاس دي اي لا في اس دي وفي اس دي انت عايز تحط اس دي اقول له هو حط اس دي كده بس هو اس دي ابعد زوم مفيش مشاكل يعني خليه زي انا عندي كام حراري واحد على ده في المحل اللي هو كارت الثاني بس الكارت اي فيصل كمان بيجيب انا الخليجي اصلا خليني حضرت شويه انا جاري منه تسيب التليفون نصيب في سنايزر سرقني انا بشتغل في الداتا فيديو انا بشتغل في الداتا فيديو في فوق كده بس هي مش هي شغل مؤتمرات انا ده مش عشان تشير على الصوت مش هدف هي سمول بروجكت هي يعني مش هدف عشان اعرف المواد اللي عندي وريحت عشان خاطر لازم زي هم شباب زي الشباب اللي هم انفصلنا ما شغال سنه لا بس واخد سنه
Good afternoon. We come to the last session here, and we're gonna present Dr. Dominique Ranucci, and he's gonna present the correlation between clinical and histological pulp diagnosis when maintaining pulp vitality in a deep caries lesion in a realistic objective. And God bless him, we're gonna give the second presentation here.
Thank you. Thank you for your kind presentation. So, in my last lecture today, I'm going to discuss the correlation between clinical and histological pulp diagnosis, and we will analyze when maintaining pulp vitality in deep caries lesion is a realistic objective. And I would say that this is the present of endodontics and maybe the future of endodontics, because I have the feeling that in the past we had been treating endodontically too many teeth with vital pulp and deep caries. So I need to start from the beginning of the story and telling you that as soon as you have a shallow caries, if I ask you, do you believe that only when you have a discoloration of the fissure and you can catch with a sharp probe on the surface, do you believe that this stage, there could be already a reaction in the bone? And many would say no, but I tell you, if you analyze it for histology, these teeth, and you follow the tubules running from the Pain caused by the application of a cold, hot, thermal or electric should cease within a few seconds. No pain to percussion or palpation, and in the radiography, normal periradicular condition. So then we say clinically this is likely a condition of reversible inflammation. And these are the criteria to assess the pulpitis as irreversible, mostly based on the severity of pain and mostly based on the fact that the pain has to be spontaneous. So, and if you touch with a stimulus, you have exaggerated response and the pain continues after removal of the stimulus. And radiographically, you may have periapical changes or not. And sometimes you have pain to percussion. The pain sometimes is described as radiating to the ear, to the neck, to other regions. Then clinically we establish the diagnosis of irreversible pulpitis. So contrary to what was said in the past, we came to the conclusion that in the clinical diagnosis of normal pulp or reversible pulpitis matched the histologic diagnosis in 96.6%, which is a very high number. And in cases with clinical and histologic diagnosis of irreversible pulpitis, the correlation was in 84%. Still, it's a high number. It's a high number. This is in contrast with previous literature, including in the old studies. And not only the serial sectioning technique, but they didn't even use a bacterial staining. So if you want to perform a study on reversibility or not, how can you avoid using a bacterial staining? So this is mandatory. So this was not used in the past studies. So all the past studies are unfortunately invalid. So the conclusion is that according to the symptoms, if you use strict clinical criteria, you have high chances to correctly diagnose the histological status. Not 100%, but you have a high status, so high possibility. And then comes a new editorial observing here? What do you observe? That the exposure here, you have not vital tissue, you have necrotic tissue. It doesn't bleed, so it is necrotic. In the surrounding area, okay, surrounding the exposure, what do you have? You have red tissue. Red means what? Red pulp tissue means hyperemia, means inflammation. It is a reaction to the bacteria present in a partial necrosis. So the indication for this is another one, not direct pulp capping, is partial pulpotomy. And on the right, you have not only necrosis, but you have dentin chips displaced into the exposed pulp tissue. So dentin chips potentially infected. Don't do pulp capping. Don't do pulp capping here, because the pulp is partially necrotic, the surface. You have soft dentin surrounding the exposure. Okay? So what... if I can start the video now. Okay, very good. We are lucky. So if you have an exposure like this, you use your sharp excavator, you see that the dentin is soft. Okay, doing so, you are pushing, you are displacing chips into the pulp. Okay, so, but we need to remove the carious dentin. Okay, so we continue, and there will be a moment that at this point you already know that we cannot consider direct pulp capping. Why? Because the surrounding dentin is infected and you have partial necrosis, yeah? And you have partial necrosis inside. So if you do pulp capping here, you are sealing bacteria in the system, and you are creating the basis for a fantastic failure, okay? So, anyway, if you have sound dentin, you control the bleeding in 2 minutes, and then you cap. And if you reopen, this is after 6 months, you may have, if diagnosis was reversible inflammation, you have the formation of mineralized tissue. And here we have to be clear on the terminology. This is called in the books is called dentin bridge. I don't like this terminology because it is a bridge, but it is not dentin, and I will show you histologically. Anyway, we like it. So clinically, and I am a clinician, we are happy when we obtain that. Another important thing, don't think that you have to reopen. I am reopening to take photomicrographs and to show you that what is the clinical response that we can get. So if you do pulp capping, you don't need to reopen. If you want to check the formation of mineralized tissue, that is okay. Large exposure, is the size of perforation of exposure important? I would say no. What is important is bacteria or not. So even exposure like this react like this after 8 months when you reopen. Beautiful healing. And this is the post-op and the 8-month follow-up. After 8 months, the tooth was restored with amalgam many years ago. You see the follow-up. 18 years, 25 years. 25 years is an unbelievable follow-up time. And I invite you to note that there are no irregular calcifications in the canals. Because many people say, if you do pulp capping, you are going to have calcifications in the canal. So you cannot negotiate the canal. This is false. Because if you have irregular calcification, it means you have inflammation. If you have inflammation, you have residual infection somewhere. So if I see after 3 months or 1 year that calcifications are forming in the canal, this is the moment to tell the patient, no, at this point, pulpectomy. Because there are, with symptoms or not, there are bacteria somewhere. But normally, you don't have calcification. And look at the canal. After 25 years, and after 25 years, the pulp responds normally to all thermal and electric pulp tests. The problem for this tooth is that amalgam after 25 years is no longer good, and you have some conditions threatening, threatening the pulp tissue, which is the cracks that you can see distally and lingually, and also there is a fracture in the enamel. So there is indication now for a new restoration, and after removal of the restorative material, you can see the cracks. okay, and cases that we used to cap in the past, today we would say don't do that, because you see that there is a partial necrosis. Anyway, this was called cap with calcium hydroxide. It was a failure after 8 months, irreversible pulpitis. What is the reason for the failure? If you look at the histology there, the reason for the failure is the presence of bacteria in the dentinal tubules of the dentin surrounding the exposure. So now, after years, we understand that this condition here never considered the rectal cap. You have to transform the treatment here in partial pulpotomy, and I'm going to show you how to do. So, but histopathology is confirming on the right, you can see that there was some formation of mineralized tissue, but there was a severe inflammation in the mesial part of the pulp, and the reason was bacterial infection. So bacteria is what counts. Then we have late failures. Late failures are, as I told you, are the failure caused by marginal leakage. This old amalgam, it failed after 5 years and 4 months. This is the margin of the cavity. I'm going to show you. You see, you have lots of bacteria and recurrent caries on the margin, and bacteria were reaching what? The holes that I told you, the irregular spaces into the bridge. You see bacteria, and they easily penetrated into the pulp and killed the pulp. So early failures and late failures always caused by bacteria. But at a certain point, from the tiny area of necrosis, you have that necrosis is expanding, and at a certain point, it involves maybe sometimes the whole tissue in the pulp chamber. But again, the rest of the tissue is alive. What if I produce a surgical wound there? What if I produce a surgical wound here, leaving the vital non-infected tissue? Can it work? So, irrespective of the clinical preliminary diagnosis of irreversible pulpitis, some pulps can be treated with partial pulpotomy. Let me show you an example. This boy is coming with severe spontaneous pain, and normally what we do is root canal treatment. And then we decide. So, yeah, immediately after anesthesia, okay, this is the movie. You see the large caries, you remove all the soft tissue. At a certain point, here is where you are. The tissue is still soft, there is caries. I don't want to open here the discussion about partial removal of caries, which is a disaster today. So, removing caries, then you have 1, 2, 3, 4 exposure, but you still have soft tissue. So we cannot leave soft tissue with bacteria there. So we do insist, and finally, this is what you get. You get large exposures of the pulp tissue with diagnosis of irreversible pulpitis. What is the indication here? The indication here is partial pulpotomy, this way. It doesn't count that the exposure is so big. And you can see on the right, the dark color means inflamed tissue, more inflamed tissue. So the indication, if you control the hemostasis, you use, in this case, calcium hydroxide, but there is no time for discussing NTA, calcium silicate cement. You can use what you want. In this case, chemically pure calcium hydroxide powder, adapt gently to the wound, okay? Remove the excess. Okay. Okay, this is at the end. This is after removing the excess of calcium hydroxide. I restore the crown and tell the patient come in 3 months, but come anytime if you have pain. Okay, so I think that very few can some people would be scared. What if the patient has pain? The patient is not having pain. There is no biological reason for the pain. You have been removing the reason for the pain. That is infection. Okay. And the patient comes 3 months later, and this is the radiograph. The pulp responds normally. You can see some, no, this is after 3 months. You see some calcification in the chamber, okay? No spontaneous pain, no provoked pain, nothing. Normal sensitivity to cold and hot test. At this point, which is irregular. This is not dentin. I do repeat, this is not dentin. But we like it. At this point, what to do? At this point, we need to protect this tissue because, as I told you, it's irregular. It has tunnels. So I like to use, for example, DICA, just to cover the new formed tissue, then build up with composite, and then this tooth will need cusp protection because this is going to break, no doubt. So, in other words, I'm trying to tell you that it is time that we reconsider the treatment of teeth with deep caries diagnosed with irreversible pulpitis. I know that this will be, there will be, I think, some war in the world because endodontists, they say, oh, I'm not working anymore if we don't do endo. No, but you have to charge for this. And another thing I would like to say is that I warn general dentists, this can be done only if you are using microscope, only if you are using asepsis. I told you at the beginning, maybe you were not careful, I said you don't usually need to remove. Okay, this is my protocol because this is, let's say, a kind of experimental treatment. So I personally, in order to come here and show you the reaction, I need to take photographs in a time. But in the routine, you should not reopen. You don't need it. Okay, so this I said clearly and I do repeat. So you just follow up, cold test, thermal test and electric test and so on. So this is all what you have to do.
Thank you for the beautiful lecture, beautiful slides, very interesting. This is actually a very controversial topic and it's been addressed several times. 2 points. I hope Dr. Mirdad is in the audience because this was one of the issues that were addressed last year. I got from what you're saying that you don't mind crowning a tooth that is vitally pulp treated, correct?
Yeah. Can you repeat? There is some echo.
Okay, I was saying you don't mind crowning, placing a crown on a tooth with a vital pulp therapy, correct? Because you were saying that that tooth needs cuspal coverage and it's vitally pulp treated, correct?
No, still I don't understand what you said. I'm sorry about that.
I'm asking if it's okay.
Yeah, maybe she can help me because. Oh, yeah, if this was your question, yes, absolutely, because you have to protect it, otherwise it is going to break. You are going to have a cusp fracture. So you treat the tooth as a normal tooth. So I don't see personally contraindication for doing a complex restorative treatment in these cases.
It's just thought that many people are scared of placing a crown on a tooth with vital pulp therapy because the patient might come back complaining and then you lose the crown and you have to...
Probably, if you in your treatment plan there is a crown, so there is a full preparation of the crown. In those cases, I would perform root canal treatment. But if you have to prepare an only, just reducing the cusp and saving some tooth structure, I don't see any indication. I do that routinely. I use only porcelain or composite only, and that's all. Yeah, maybe the trauma of the full crown preparation is too much. In those cases, you have to think, you have to examine the case by case. Okay, but normally there are no contraindication for cusp coverage.
The second question is just the last one. Hypothetically, what's the problem if the pulp calcifies? So if we do a vital pulp therapy...
If the pulp calcifies?
Yes.
If the pulp calcifies, yeah, this is general pathology. So calcifications occurring in the pulp are called dystrophic calcifications, okay? So normally the calcification following pulp capping happens only under the capped area, okay? And it is also a kind of dystrophic calcification, not in the rest of the pulp. If in your follow-up you see that there are calcification, this is general pathology. It means that there is inflammation, there is irritation. So it is an indirect sign. And this is the reason why it has to warn you, pay attention. There are no symptoms, but there is ongoing inflammation in the pulp. And this is telling you, if you are waiting, if you have pulp breakdown, you will be not able to negotiate the canals. So if you see these signs, which I do repeat, are indirect signs of the ongoing pathology, then you have to recommend your patient, now it is time to do pulpectomy, to do root canal treatment. Okay, so in the radiograph, you can observe, you can have indirect signs if there is inflammation or not. Well, I mentioned calcification, but I forgot to mention that you may also observe the opposite, which is resorption. So resorption and apposition, they go together, but they are the consequence of continuous inflammation in the pulp. So this is the reason why, if this occurs, remove the pulp. So we have to learn the pulp pathology in order to manage accurately this point.
Thank you.
At the end, we would like to thank Dr. Dominique Ragucci and we're going to wrap this beautiful day with the last presentation with Dr. Azim. I'll introduce Dr. Azim. He is the Division Head and Director of Endodontic and Postgraduate Program at the University of Buffalo, New York. He maintained private practice at the same time. He's also a founder and a chief editor of EndoLet. Dr. Azim, he graduated of Cairo University, and in 2010, he joined the postdoctorate program at Columbia University, and he worked as an assistant professor in endodontics at University of Tennessee Health Science Center. He's a diplomate of American Board of Endodontics, and he was awarded several awards. One of them is the first prize in American Association of Endodontics for Research in 2012, and again in 2013, actually he got again the first prize of Pan-American Research at the conference. He has numerous publications, and he's in a peer-reviewed journal, and he's a scientific advisory board of Journal of Endodontics and a reviewer for many endodontic journals. Please welcome Dr. Azim.
All right, so this will take a couple of minutes to get this computer in. Right, thank you. Third time in Saudi Arabia, second time in Riyadh. It's always a pleasure to meet a lot of friends, colleagues. We have a very old tradition with a lot of students coming to University of Buffalo from Saudi Arabia, especially from the university here in Riyadh. So I bring greetings actually from everybody in my school. We have the first row are all Saudi students. A couple of them are from that may change the way we do root canals to some degree, or to help us achieve the goal that we are trying to achieve during root canal instrumentation. So, if we want to ask for me, I would break it down into 3 things. If I'm looking at the ideal 5, okay, I'm going to use that mic. I don't think it's going to help. Okay. It's more problem than I thought. Okay. Yeah, I did a mistake and I decided to wear the mic. Okay, so just give me 1 second to fix this issue. Okay. All right. Everybody can hear me now, right? So we have 3 main things if we want to really have an ideal instrument or to choose an instrument. It would be an instrument that is flexible, instrument that has definitely some sort of strength so it doesn't break during our treatment, and an instrument that can engage most of the canal wall so that we can touch as much as possible. We listened for the past hour and a half, we listened for Dr. Rikuchi talking about how biofilms kind of invade the root canal system, and a big part of it is that our instruments are not touching these canal walls. So if we are able to achieve more touching of the canal wall, probably we'll reach our goal a little bit faster. And if we're going to talk about the instruments, I think in the last 10 years we've been very lucky as specialists and clinicians to have improvements in the rotary instruments that we are working with. For the longest time, we know that rotary instruments are present in two primary phases. We have the Martensite phase, the flexible phase, and it allows the instrument to go through the canal very flexibly. But the issue is that it doesn't have a very good cutting efficiency. The other phase, which is most of the rotary instruments that came out initially had, which is the austenite phase, which is the stiffer form, but unfortunately it lacks flexibility. So just to explain this a little bit more, usually this is how a or 35. But you can see these curvatures are quite abrupt, and we can actually manage them quite nicely without any problem, without transporting the canal much, without breaking the instruments, and this way we can achieve our mechanical objectives in terms of disinfecting the canal. This is one of my favorite cases. Central incisor, we often think it's not that much of a difficult case. This case definitely proves otherwise. There was a sinus tract traced to the mid-root, so we were wondering what's going on here. Take a look at the CBCT. You can see a big lateral lesion related to this tooth. As you move into the scan, you can clearly see a lateral canal. And you can see clearly an area with pulp tissue, most likely infection. And again, for the last, I'm not going to repeat again what Dr. Kuchi was talking, but he stressed so much on how these spaces, if not addressed, may become a potential problem. Take a look at the micro-CT of a mandibular molar. See how the canals are not rounded at all. It's very difficult to clean these canals. You can see almost the tooth is laughing at us because we are not able to address all the entire canal space. And we are using, for the most of our time, we're using rounded instruments to treat a non-rounded space. So we have to come up with some ideas to be able to clean these spaces more predictably. This is a lower anterior tooth, a case which we think, or we always think this is just one canal, maybe it's not too difficult to clean. As we are going through the instrumentation of this, you can see that we are not addressing the entire canal wall. And we don't want to bring these canals to a very big size because we know also the limitation of that. So if this is how a canal would look like after instrumentation, and you want to address the entire canal space, this is how big you would need to instrument. Some instruments today that we have studied extensively in our school. I'm going to be discussing in details a bunch of articles that we have published in the last couple of years on this instrument, the XP Shaper, which I think might be quite an interesting instrument to use in the clinical practice today. So let's just, in case you are not familiar with the instruments, given that it is relatively new, I just want to give some details about that instrument. It's made from a max wire alloy, so this is some sort of a patented alloy from the company that produces it, which is FKG from Switzerland. The taper is a 2701, which is quite interesting in its own, because we never had a 27 before, and we never had an 01 before, so it was actually a nice combination that would be intriguing on its own to study. It comes like in a snake-shaped appearance. I mean, we've seen some instruments looking like that before. We saw something like a true shape, for example, but it definitely behaves in a very different way, and it's intended to be more of a single-file system. I think it may not be the case, but definitely it can help us to reach new levels of disinfection, and it has the potential capacity to expand, and I'm definitely going to expand on that in the next couple of minutes. So this is how the tip of this instrument looks like. Although the instrument is 2701, but actually the tip of the instrument, the very far tip, the non-cutting edge of it is a size 15, and the first flute is located as a type size 27. This is how a normal tip of a rotary file would look like. You can see that the non-cutting part is extremely short, it's around 0.5 millimeter, versus for an XP Shaper, it comes with what they call a booster tip. So you actually have double the size of the non-cutting part, so it's around 1 millimeter in length. This is where it's size 15, and this is another 0.5 millimeter until it reaches a 27. As the instrument rotates, you can see that it is not rotating in one area like a normal rotary file that we use. It's dancing
as it's working. So when this file came out first, the company came to us at the University of Buffalo to test that instrument before it was even released in the market. And we thought, you know what, let's just put it to the test. Let's see what this instrument is all about. So we designed a study and to compare between the XP Shaper interesting, it was not the case. So at the apical area, you can see the differences were not that much. But in the apical 1/3, you can see that the taper of XP was around 5 with a very high standard deviation, which means that every case basically is prepared to a different size, which makes a lot of sense because our anatomies are also non-standardized. Versus with the vortex, you can see it's always 0.4 taper with a very low standard deviation. So apical, middle, and coronal was always 0.4 versus XP. You can see the taper is changing with a wide variation or wide standard deviation. So this was the first information we gained when we tested that instrument. We definitely knew that we are dealing with something different. It's not what we have been always working with. It's not the regular rotary instrument that you have in your cabinet. Because of its behavior, we were also wondering how this instrument would fail. What would be the mode of failure? We know that we are dealing with two modes of failure primarily, so either the instrument would break under cyclic fatigue or under torsional stresses. When it comes to cyclic fatigue, it is well known that as the size of the instrument decreases, the resistance to cyclic fatigue increases. And the reality here is that this instrument is a 2701. It's probably the smallest instrument ever developed for that purpose. It's even smaller than some of our glide path instruments that we use because they taper as they go more coronally versus this instruments maintain a very small taper. So given that it is already small size, we were expecting that it will have a very high resistance to cyclic fatigue. Now the other thing is torsional stresses, which is completely the opposite. So as the instrument size decreases, your resistance or your torsional, the instrument can be subjected more to torsional stresses, can break quicker under torsional stresses. So to overcome that issue, there is actually one clinical way that you can manage is to increase the speed of the instrument as it rotates inside the canal. But the issue is that as we increase the speed, we may reach the cyclic fatigue limit of the instrument also faster. So it's kind of, you have to balance it somehow. So again, we put the instrument to the test, and we start doing cyclic manufacturer tells us, please enlarge the canal to size 15 before you go with my rotary instrument. So honestly, I don't think, I want somebody to help me from size 6 to size 15. This is where we have limitation. And that's where we thought this instrument might be quite interesting to use. So the first thing we wondered, what if we increased the RPM on this instrument a little bit more? To a certain speed. We're not going to disclose any speeds now. But what would be the risks? What kind of glide path file do we need prior? So do we need to go up to 15, or can we bring it maybe down a little bit more? And how fast we will be efficient in finishing the treatment. And when I say fast, I'm not intending that you necessarily want to finish the root canal in 10 minutes. But I mean that the mechanical aspect of your treatment would be finished quickly, and then you can spend the rest of your treatment between irrigating, medicating, whatever would you prefer. So I'm going to show you some of the initial testing that we did in our lab. We wanted to see first how this file will behave. And this is a non-instrumented canal at all in a plastic tooth, and see how the instrument is actually expanding that canal. It was quite interesting here to see that without even any kind of patency or enlarging this canal, the canal space has enlarged significantly by taking the speed a little bit higher. But this is a plastic tooth, so we all know how easy sometimes to do this work. So we decided to go a little bit on natural teeth and test further. And we started with this tooth. You can see obviously that we have some degree of curvatures. And you can see here, this is me trying to see where is the capacity of this instrument. And we really tested many, many speeds. The recommended speed of that instrument by the manufacturer is to be used at 1,000 RPM. And they thought 1,000 is already too high. But I thought that it needs to go higher than 1,000. So this is actually operating the instrument at 3,000 RPM after getting just patency with size 8. And you can see clearly from the X-ray that was showing that the canal was actually curved at the 8th third. Going with this speed with most rotary instruments would end up with a transportation or perforation. But in only 14 seconds, we were able to fit a master cone of a 3004 down to the apex. We didn't do this just one time. We did it several times, and every time we get the same results. So we thought this is actually quite interesting, because as the canal size is smaller, it actually gives more room for the instrument to expand. And let me illustrate with one example. Every time you meet a resistance, what happens to the instrument? It expands more. In fact, if the canal is so big, the instrument will never expand because there is no resistance to prevent to allow the expansion. So we went for the next obvious logical experiment, which is to compare between 1,000 RPM versus 3,000 RPM. One with a glide path size 15, as the manufacturer recommends, and the other one using our own protocol, which is just patency to size 8, and then you go immediately to 3,000 RPM to the working length. And believe me, doing these studies are not as easy as you think in today's world if we really want to get the right information. So the first thing we do is that we actually take micro-CT images of a lot of teeth, a lot of mandibular molars that we want to test our experiment on. And then we start matching canals to make sure that the one we are treating from one group is a close match to the other one. So you can see, for example, here some of the teeth, like if we look at this tooth, for example, you can see that these canals are get patency with size 8, followed by XP at 3000 to your working length. The same thing, check patency, and then 10 strokes with the XP again until a 3004 cone would fit, and if it fails, we try 3 attempts, same protocol. So the first information we got was the number of strokes to the working length. So with the XP at 1000, it took around 5 strokes, which is pretty much what the manufacturer declares, that it takes around 5 strokes to reach the working length. With an average 5.25, it can go up to 7 strokes, so it ranges between 3 and 7 to get down to the working length. But with XP, it was almost half of that. So it took us only around 2.5 strokes to reach the working length, and in some cases we were able to get it down to the working length from the first stroke. The second thing was the time of instrumentation, and we wanted to know how long it's going to take us to do a prep with either techniques. You can see with the XP it took around 38 seconds per canal, versus at 3000 it took around 26 seconds. Sometimes some people would ask, so what, 26, 38, this is all short duration. When you translate that to a clinical time, actually it's way more, and then you multiply that with 3 canals that you have, it's more and more. Because you add irrigation, you add talking to the assistant factors and things like that, this takes a little bit more time. Then the true thing that we wanted to see also, how many times we will be able to fit a 3004 cone. Because we thought initially when we looked at this instrument, the company recommends to use this instrument and then to fit a 3004 cone. And we knew that you cannot standardize that. Because this is a non-standardized instrument to start with. It's not going to give us the same preparation every time. So will it fit a 3004 cone every time? This was also something we were interested to see. So you can see with the XP at 1000 RPM, only 8 out of 20 molars we were able, or canals, we were able to fit a 3004 cone. Versus at 3000 in 16, so almost double the number of cases we were able to fit the cone down to the working length. And the next logical thing was also to look at any kind of transportation that occurred during instrumentation, because this is something we would be interested in. And now I'm walking you through the canals, the micro-CT work that we did. The red is the pre, and the green is the post. The canal on the left is at 3000, the canal on the right is at 1000. We were able to touch more canal wall with the 3000 RPM, and it made complete sense, because you have a smaller canal that allowed for further expansion of the instrument and accordingly touching more canal walls. And this research we just completed just a few days before coming here. So you're the first actually to see these results, and it was done by one of our students, Dr. Marian Weber. Then we start to look at other factors into the treatment. We tried to split these canals and look at the taper at different parts of the canal. So we took tapers in different areas, at the working length at 1 millimeter, 3 millimeter, and 5 millimeter. So you can see at the working length with the 1000, because we had to go sometimes in 3 attempts, you can see we only were able to fit the gap aperture in 8 out of 20 cases, which means that the other 12 cases we had to try 3 attempts to reach the working length with 10 strokes every time. So the working length enlarged from size 30 to size 40. And yet the gap aperture was not fitting, because it created at 1 millimeter a very small taper. It's not expanding anymore. It became so much under stress that the instrument started to straighten a little bit and not actually expanding any further. Versus the one at the 3000 at 1 millimeter, it gave us a perfect 04 preparation. At 3 millimeter, it became a little bit bigger, and as we go bigger, we calculated the taper here. So the taper with the XP at 3000 was around 0.5 taper, which is equivalent to how we used to do hand instrumentation in the past, versus the taper with the 1000 was less than 04 taper, which explains why our gap aperture was failing to fit in the apical area. And then we also analyzed the instruments that we worked with. We wanted to see how much deformation happened to these instruments. You can see the instrument on the left side, it maintained its curvy shape to a great extent, versus the instrument on the right side, with the 1000, it starts straightening a little bit further. So we did an SEM analysis to these instruments to see how much destruction happened to them. And we definitely saw more deformation happening when we used the instrument at 1000 RPM. We took it a little bit even further. It's very interesting how your research can keep on being modified as you go when you find an information and then you want to find another information to make sure that you are actually presenting the right information. So we decided to create some sort of scaling to these instruments to give them a number from 1 to 4. The control is a new instrument, and then size 1 is an instrument that we called it okay, all right? So the instrument didn't really undergo a lot of damage. 2, you start to have apical straightening of the instrument. 3, it's almost complete straightening. And 4, you would start to have some deformation or unwinding of the flutes. So we did the comparison. We saw that 6 out of the 20 files that we used were maintained as an okay. The instrument was not damaged at all. With apical straightening and complete straightening, you can see that we had some in each. But most of the samples were, almost 50% of the samples had complete straightening after we used 1,000 RPM. And we had 3 cases of complete distortion of the instrument in the 1,000 RPM group versus just 1 in the 3,000 group. And this is an example of the SEM images. Look how the instrument looks like after we use it. Definitely major deformation. So we thought that this would be the ideal protocol actually to use that instrument, is to get patency, to use XP at 3,000, just one time. And then you finish your preparation with a regular 30 or 4 file. And this is not for cleaning purposes, but more from a clinical aspect to be able to actually fill this canal, because otherwise you will keep on trying to fit cones that doesn't fit. So this way you are actually getting the best of both worlds. You are cleaning more and you are making your clinical approach a little bit easier and faster. And up to my knowledge, we really do not have shaping instruments that can go directly like that from such a small size. So it can be quite an interesting approach for you in the clinic to minimize your chair time. Let's give some clinical examples. You can see this upper molar presented for root canal treatment. And this is how the axis looked like after we removed all the restoration caries. So you can see that the canals are quite narrow. And everybody in the room knows that these are the kind of cases that you will spend some time trying to bring your hand files down to the working length. It does take time. But the moment we were able to bring size 8 down to the working length, we went immediately to 3,000 RPM to open our mesiobuccals and distal canals. And this was the final after restoring the tooth with a fiber post and core. You can see the preparation is actually quite minimal. It's not as big as we were used to do around 10 years ago, 15 years ago with the huge tapers that we used to do to be able to deliver our irrigants or to be able to disinfect our canals properly. Now you can achieve that with way more conservative preparation. Another example, same results. It's quite predictable. In fact, this case is quite interesting because this patient had 2 mesiobuccal canals and I was suspecting a middle mesial canal in this case. So I wanted to see if the XP will be able actually to drive me through that middle mesial canal. And I started first with the XP at 1,000 RPM to see if it's actually going to be able to get into the canal. So this is XP at 1,000. You can see I'm trying to get into that canal. I'm trying to push my way in. It's not budging. It's not getting into this canal. So I stopped, increased the RPM to 3,000, and then immediately I was able to navigate through this canal. So that booster tip with that speed enhances that penetration that we need and minimizes also the chances of this file getting locked into the canal and breaking. The common problem we had with rotary instruments when we are trying to push them into a place where they don't want to go. So they snap and break. If they are such a big instruments, they will start transporting your canal space. And this is the final look after we completed the cleaning and shaping, and this was the obturation. This instrument is not only unique in the way it can treat your canals for initial treatment, but for retreatment it also has huge value. In fact, in our school today, our residents, this is their first instrument that they bring out for any retreatment case, and I'll show you why now. So this is just an extracted tooth that we were attempting and trying to use the 3D XP shaper on during instrumentation. And the first thing we did is trying to follow the manufacturer's protocol for retreatment. So you can see here I'm actually pushing on that gutta-percha at 1000 RPM and I'm getting nothing. And this is a tooth that has been obturated only for 1 week. We know the sealer is not that, has not set that much, gutta-percha is not that hard. It should be an easy retreat to some degree, but nothing. I'm really pushing hard and I'm not getting any entrance into that canal. I'm pushing to a level where I completely damaged that file. It didn't break, that's the thing. It completely got distorted, but it did not separate. So this instrument does not have a penetration power in retreatments under a low speed. So we went to the next obvious thing, is to test it at higher speed. And now I want you to see how the gutta-percha is coming out, because you're going to see it coming out in a way you've never seen before. The gutta-percha is not coming out as debris or small pieces, it's coming out as a one big, nice cone. And I'm slowing the speed here just to see how it goes around. This instrument doesn't have the strength to go through gutta-percha. It wants to go to the area between the gutta-percha and your canal, and that's why it brings the gutta-percha out as a one piece or as a strings or strands rather than bringing it as a small chunks that tend to be even pushed sometimes into the apex. Look at that. This is not something that we often, how we bring gutta-percha out. But I'm not here to show you only some extracted teeth. I want to show you some properly done, executed research to really see the value of this instrument. So this paper came out last November in the Journal of Endodontics, and we were looking into compare 20 mandibular incisors. Again, we chose the incisors for the same purpose. These teeth are really difficult to clean. And we cleaned and shaped them to size 30/04, obturated them, left them set for around a month, and then we decided to retreat using one file system. And today we have some manufacturers claiming that their instrument can be a one file system. So we thought, let's compare the XP Shaper to Wave 1 Gold, because it's a reciprocating system, it's a single file approach, and to HiFlex EDM, which is a rotary system from Coltine, and it's also sold or marketed in the same manner that it's a single file system. And we looked at three things: the amount of gutta-percha remaining after you do the retreatments, the amount of debris extrusion that can occur during retreatment, and how long it's going to take us to actually finish the treatment. So these are the three instruments that we were comparing, and we went and started to look how much gutta-percha is remaining. You can see clearly that with the Wave 1 Gold, it left significant amount of gutta-percha, versus the EDM, HiFlex EDM, it actually performed a little better, and we had the best performance that was with the XP at the 3000 RPM. So if we look at the remaining gutta-percha, Wave 1 Gold left around 25% of the remaining gutta-percha inside the canal. And XP was the least. There was no statistically significant difference though between the EDM and the XP. Considering the amount of debris remaining inside the root canal space, again, there were no statistical significance between all of them. It's interesting that you see that Wave 1 Gold left the least amount of debris, right? But it also left the most amount of gutta-percha. And this is sometimes the limitation of the studies that we read. So we see a lot of studies talking about cyclic fatigue of instruments, but we never correlate cyclic fatigue to performance. It doesn't matter if your file breaks after 1 million cycles if it doesn't clean your canal, or it doesn't do the job. It doesn't matter if it breaks after 1 minute if you were able to do the job 10 times, which means that you only need 10 seconds to do the job. So we have to correlate these two things together, and I think this is quite lacking in our literature. So you'll see the time of instrumentation with Wave 1 Gold was even the most. So it took the longest to clean the canal, and it left the most amount of gutta-percha inside the canal. So we wanted to test also the cyclic fatigue differences between those three instruments. And we did the same test. We like to call this machine the Terminator, because every file ends, breaks at the end of the treatment. And you can see here that Wave 1 Gold took the longest, for example, to break under our cyclic fatigue. And obviously XP at 3000 broke at a very short period in a 90-degree curvature. But that doesn't mean anything, because if I'm able to treat 5 canals or to finish my job within a shorter period compared to an instrument that takes forever to finish, it really doesn't count the cycles, number of cycles to failure. In this study, we had only one case of instrument separation, and that was in the wave 1 goal that has the highest resistance cyclic fatigue. So this whole cyclic fatigue alone thing, debris exclusion alone thing, really is not correct, and we should stop actually doing studies like that. And we tried to actually lure to this in our study. We said only evaluating the time for single-file instruments to mechanically fail may provide an incorrect assumption about the clinical performance of these instruments. Correlating the performance of single-file system to achieve their clinical task with the time required to mechanically fail will allow better understanding of these instruments in a clinical setting. And now let's go to see some clinical examples as well. So this is a case was referred for retreatment, and I'm just showing you how the gutta-percha is coming out. It's very, very quick and very clean kind of instrumentation. I personally do not like to use solvents at all during retreatment because they make things, in my opinion, a little bit messy, gutta-percha sticking more. And sometimes we had to go for them because the rotary file leaves a lot of material on the wall. But this instrument is going the other way around. It's actually going around the wall and bringing your material all out in one piece. And this was the outcome of the treatment after we finished. You can see the preparation is not too big. We often finish retreatments with canals looking way bigger than the way we started the treatment. And that's because we opened them so big. We use bigger taper to be able to clean more of the root canal space. Another case here referred for the same purpose. Obviously, the case was not restored for a long time. Patients started to develop symptoms, so we went for a retreatment. And I'm showing you my retreatment protocol. I do not use solvents. I usually use heat for this. You can see here, I want you to notice, please, how the gutta-percha is going to come out from during the clinical treatment. So just heat the gutta-percha a little bit, and look how the gutta-percha is going to come out. We do not get gutta-percha coming out like that with rotary files. Let's look at the other canal. Maybe we'll go deeper a little bit into this canal. It's not going through the gutta-percha, it's going around the gutta-percha, bringing it all out in one piece. Look at this. This creates a much cleaner way of cleaning the canal, actually. Because the worst is pushing those debris either in or laterally, creating it more difficult to irrigate and disinfect the root canal space. Going to the last distal canal. This video is bringing these treatments in around 2 minutes after cutting, but I can tell you the exact amount it took me in this particular case to remove all the gutta-percha. And I'm not saying it's a difficult retreat, this is an easy retreat. Gutta-percha is filled to the length. But the whole mechanical portion of this treatment took exactly 9.5 minutes. I do retreatments all the time, but I do not being able to finish the mechanical aspects of it within that such a short period. And this was the outcome after, this is the pre-op, and this is the outcome. We placed 2 fiber posts in the distal to support this, the tooth a little bit more. Towards the end now, since we are finishing, I want to show you one last video that actually was quite interesting. I wanted to see, again, we're just pushing the limit. We have a broken instrument here in this canal, and I'm trying to bypass it with a size 15, okay? Just to show, like, because the tip of the instrument is 15, so I'm just showing here that the 15 actually does not get you through that broken instrument. Now I'm putting the XP in there, and everybody in this room knows very well you do not put a rotary file next to another rotary file because you're gonna break it right next to it. But this is an extracted tooth, or this is a plastic tooth. I was sure that that patient will not really complain. So you can see here how the file is actually going between the file and the broken instrument without really engaging into that instrument at all, because it does not want to, it doesn't want any conflict, this instrument. It just want to go to the spaces that are available. So I thought, since I was able to bypass it, let me play a little bit more. Let me try to actually remove it with that instrument. So you can see I'm actually trying to engage it. Here now we're irrigating. Already the canal is cleaned around it. And again, this is a plastic tooth. I don't think you can mimic that all the time in the clinic. We tried it sometimes, it worked sometimes, it didn't work other times. But here we thought, okay, let's see if I can actually dislodge it from the other end. And here you go, the whole file came out. Doesn't really happen all the time in the clinic, but this is just, I can tell you today, if I bypass a broken file, I put the XP shaper next to it very, very comfortably and confidently. So, can one file does it all? It's a good question. I think we may have reached the point to start to question this, because we have a good history of developing rotary instruments and working with them and understanding it better. And I think we are getting close. We are not there yet, but we are very, very close. And that's why, again, I want to go back to the whole idea of it's a new concept. So there can be new philosophies of treatment. We do not have necessarily to follow the same way we do root canals with rotary files, regular solid core rotary files, when we are thinking of more of a 3D adaptive instrument. And again, I don't think we are completely there yet, just due to the limitation of the instrument. The instrument may straighten on you faster, may not expand to the same level every time. And that's why my recommended protocol using this instrument is to use patency, use the XP at 3000. Be careful sometimes also, because at this speed it's very hard sometimes to control the instrument. So instead of going to the working length or half a millimeter from, if you're working like this half millimeter from where you should be, I would make it at 1 millimeter with the 3000, so that to avoid that unintentional passing to the apical area. And then you take a 30 or 4 or 5 from whatever manufacturer you like to work with, just to shape the last portion or last half millimeter of your preparation to be able to fit a gutta-percha cone quite predictably. So we can clearly see from the data we're presenting, and again, I make it very clear when I talk about an instrument, I'm not affiliated necessarily with the company, so I want to make that very clear as well. Nevertheless, I'm being paid to give this lecture, so also I would like to disclose that. But you get better adaptation with this find to your canal walls. That's for sure. This is the research that we did in our school. I'm not talking about other work, this is my work. You get a more conservative preparation with this instrument. You do not need to over-taper your canal to be able to clean it properly. And definitely increasing the speed would improve its performance. In fact, the manufacturer now start to listen, and they are changing their speeds or the recommended speed to be used with this instrument. And in my opinion, it's the ideal instrument for retreatment. It will make your life definitely much better. If my residents embrace it, and I can tell you my residents do not always listen to me, okay? So anybody teaching in the room probably knows the rebellious nature of our students. But I can tell you this is one of the things that they definitely listen to me in, that this is their first instrument of choice in endodontic treatment, and I'm sure it's going to make quite a difference in your practice. I hope I wasn't too long, and thank you very much for hosting me, and it's always a pleasure to be here, and I'm ready to take any questions. Thank you very much. So I'll repeat the question. That the question is, I changed the speed from 300 to 3000. No, the recommended speed for this instrument by the manufacturer is 1000. So we changed from 1000 to 3000.
What about the torque?
The torque? Actually, so this instrument works at a very low torque. Actually, the recommendation is 1 Newton centimeter square, which is basically similar to, most likely to your slow speed handpiece.
What about the cross-section of the instrument?
This is a triangular cross-section instrument. This we covered in the first part of the lecture. It's a triangular cross-section. Most of the rotary instruments in today's market are moving to the triangular cross-section because it appears to be the most appropriate for a rotating instrument.
Thank you.
Thanks. Yes? I'm sorry, I can't hear you.
Thank you so much, Doctor, for the informative lecture.
Thank you.
I would like to ask about the crack. Would you think that increasing the speed would increase the micro crack potential in the canal?
You mean in the canal? I thought in the file.
No.
Okay. I mean, technically, really do not see those small fracture lines or cracking within the instrument itself. This instrument So the question is, should we advocate faster treatment? Because we should emphasize, or the length of the treatment helps better with better disinfection, you will leave irrigants for a longer time and so on and so forth, right? Did that catch you? Okay. So to start with, this is not advocating that you finish your treatment faster. This is making your mechanical aspect of the treatment quicker. And I think I mentioned that during the lecture. You can spend more time now on actually irrigation activation, on you want to place intracanal medication, you can definitely do that. But keep in mind also, if you are instrumenting your canal in, let's say, we finish here in, let's say, 5 minutes, and you would clean and shake in 15 minutes, okay? That sounds realistic? So in these 15 minutes, how much of your irrigant that you're delivering going to the apical area? Very little. It goes towards the end of the treatment. So technically, your best irrigation is achieved at the end of the treatment, not at the beginning of the treatment. So I'm helping you now to reach the end of the mechanical part quicker so that you can irrigate, activate, do whatever you want. This has by no means advocating for let's seal the canal in 3 minutes. No, this is not the reason. But it's a fact that we as clinicians struggle a lot with a lot of things in the clinic. One of them primarily is taking a canal from size 8 to size 15. I'm telling you, this is my biggest challenge. And every endodontist you will ask, they will say the same thing. Biggest challenge. Give me any file after size 15 and I'll do it. So if I'm helping you with that part, I'm making your treatment fast, making you less tests during treatment. And then you can spend as much time you want to disinfect the canal. Okay. Any more questions? Yes. So the question is, did we use any instrument to flare the canal? Are we, the coronal portion of the canal, you're talking in initial treats or retreats? Both? We did not. So we went straight to the instrument. And that's, again, it actually, the whole concept of coronal flaring comes from our understanding that when you do coronal flaring, you will create less stress on your instrument, so it will not break. This instrument works better because it can expand more when the canal is smaller. So I can tell you, put this instrument in a palatal canal, you are getting nothing because the canal is so big. You're getting very minimal work going forward. But as you put it in a very small canal, what does the file want to do? It wants to expand, it wants to reach its shape. So you get better disinfection this way, or better mechanical action this way, if you want to talk about the amount of walls being touched. So I definitely advocate not to do coronal flaring with this instrument. In fact, the opposite. Keep the canal small and start with it small so that you can touch more canal wall. So what is proper coronal flaring? Yeah, but if you, that's a very good point. So I'll raise it so that everybody hears it. The talk is, will we be able to get the proper taper of the canal when we are going straight to that instrument versus coronal flaring? So what is the purpose of coronal flaring and getting that taper preparation to begin with? The purpose is to be able, two things, to deliver your air guns apically and to minimize the fracture on your instrument, minimize the resistance on your instrument so that it won't break. That applies to your solid core rotary files. This is not a solid core rotary file. This is an adaptive core rotary file. It adapts to the canal wall better. And if your goal is to touch more canal wall, we have proven that it touches more walls when you use it compared to something that you go coronal flaring and then you go crown down approach, which we usually did before. So it's just because it's a new concept, again, that's why I stressed on new concept, new philosophy, we may need to change things or our understanding of things based on a new technology that we use. More questions? Yeah, one question. Asking if we compare this instrument to other instruments using SEM. We have not done that yet, okay? So we have not compared an XP compared to, let's say, a vortex under SEM. SEM will give you a value. Actually, we did SEM after fracture. We didn't do before fracture, if you want to see the amount of damage that happens to the instrument. We only did it between two groups within the XP. Most of our instruments, most of them, okay, when they break in the clinic, if they break under torsion, then most likely we are using them wrong. This is most likely. Or we decided to push them where they should not go. They most likely break under cyclic fatigue more, because we often want to use the file more time so that we don't pay a lot of money in throwing the instruments earlier. When we compare the SEM after fracture, we noticed that there was no difference in the pattern of fracture between any of the instruments. In fact, it was one of the findings from our paper that was published last December. No difference in the pattern. But if you're talking about torsion, this is actually what we are going to look at when we are comparing to other rotary files. But bear in mind, torsion alone doesn't mean anything. Okay? Again, if you see damage on an instrument, okay, this instrument got damaged, this instrument did not get damaged. The question is, did both instruments do their jobs or not? Because if I'm putting an instrument that does not do the job, does not clean all the canal space appropriately or in a good time, then I'm not comparing apples to apples, right? So both of them have to achieve the goal, and then you can compare them.
Yes. I have a question here. Would you use one file for each canal in multiple canal teeth, or would you use one for all of them?
That's a perfect question, because what we noticed, as you've seen, I mean, for study purposes, we often use one file per canal because we want to standardize things. But what we've noticed that if you use it at the 3000 RPM, this file probably will be able to be used more efficiently in other canals, versus at 1000 RPM, it loses some of its value. I don't want to say that it will expand or it's going to break immediately, because that's not the case from a clinical experience. I personally use one file per tooth, so I do not sterilize files, I do not reuse them. And I don't think we should be doing that, but that's maybe a discussion for a different day. But can this do a full molar? Absolutely. Will it break during the molar? I guarantee you not. Okay, so for a new file, most likely it's not going to break if you are using it properly. Or is it expected to be broken? I don't think so. I don't think that will be the case.
Even in the retreatment cases?
Even
in the retreatment cases?
In retreatment cases, believe it or not, it's easier, actually. It's actually easier in retreatment cases. Most of the time, so I'd say we've noticed some fractures, of course, in some of these instruments. Many of them, sometimes we are pushing on the instrument so much, and we see that it is expanding a lot, and then it would get lodged in one area and fracturing. But it would not, with retreatment, you have less resistance, actually, because you are going between garapercha and dentin, versus in the initial treatment, you're going between dentin and dentin, which is technically harder. So between the heat generated from the speed and the softer sides, or one side is actually slightly softer, it actually works longer. And we didn't notice any kind of fracture when we did our retreatment study. We noticed fracture in their other rotary files, but not with the XP.
Thank you so much.
Thank you. Yes? So the question is, what does it mean the file expand? You can see from the nature of the instrument that it is not your regular looking rotary file. I don't know if we can bring maybe the screen again. I would like to bring. Yes. So well, that's why I would like. Can you connect me again to the screen, please? So maybe I'll bring you a slide that can explain that a little better. So the reason why the instrument can expand, because it is not a straight instrument. So as it meets resistance at the apex, it expands laterally. And maybe this video can illustrate what I'm saying quite well over here. See, as you push the instrument towards resistance, see what happens to the core? It starts expanding. You can see it even better in here, in that example we showed earlier. This is a small canal, we all agree on this. Look what happens to the body of the canal as we are going in. So it's if it's let's say it's the same size as your canal, right? Because it's a 2701, but it ends up giving a preparation that is bigger than a 3004. So obviously it gives a preparation bigger than its initial size. So there's only one explanation, that it expands. And we see that from that video that I showed you. So it meets resistance at some point, making the body of the file to flare more and touch more canal walls. Any other questions? Yes, please. So the question in the case of the lateral canal, in the case of a large canal, what would you do? So I can tell you, this instrument would not be the perfect instrument used for a large canal. I'm not saying it's not going to touch, but I don't think it's going to do anything better than your average rotary files. But on the other hand, large canals, we do not have problems usually of instrumenting them much, because they are so big they can allow a good irrigation flow. So if you look today, for example, at the regenerative protocol that we have from the AAE, in large anterior cases, very large open apex, technically your file would not touch anything. The recommended disinfection protocol is no instrumentation. So technically, if you have a big canal, you have a good flow of irrigant, you reached your goal in a different way. The question that was coming earlier about how much time we should spend on touching or irrigating the canal. This is what we This is what we completely do in the regenerative protocol. And the solution for this, so we discussed with the manufacturer some solutions. The solution is to, if we really want to address mechanically some of these canal walls, they need to develop for us an instrument that is slightly bigger in size. Or these loops would be slightly bigger. It doesn't have to be big in the apex, but these loops needs to be sometimes wider to address more anatomy. But so far, this is the only instrument we have. Yes, the finisher can be addressed for this. Unfortunately, because of the time of my lecture, it was only 45 minutes, so we were unable to expand more on the finisher that we also did a lot of studies on. Yesterday, we gave a course here and we addressed the finisher extensively. But unfortunately, just the time. But you're absolutely right. The finisher can be a good solution. However, I think there is also some limitation with it. And I think we're running out of time. They're going to kick me out now, so I think we will have to. Maybe we can discuss it after the talk. All right. Thank you.
At the end, we would like to thank Dr. Azim, not just for the presentation, but for his energy being the last presenter here. MashaAllah. It was really a great day. It was very overwhelming, and we would like to thank our audience for being here around this time. Thank you very much.
Thank you very much. We will take a break 6:30 for the Maghrib break, Sunday Maghrib, and then we will start our celebration. Okay, and at the end, we will have our gala dinner, please, at around 7:30. Please be around. We'll see you after prayer.